Good morning, everybody. Apologies for, I guess there was some technical difficulties. We were trying to simulcast over VMR for some folks that were watching remotely. Unfortunately, they couldn't get it to work. But anyway, my name is Andy McGuire. I'm with Jensen Hughes, formerly RPA. I've been here a couple times doing our surgical fire safety, and this is our annual surgical fire safety in-service. So we're going to spend from here till about 8 o'clock, so about the next 50 minutes, going over the surgical fire safety presentation, and then we'll spend the rest of the day doing some hands-on small group training in various locations. So we hope to see some of you throughout the day. So I'm going to go a little quickly since we lost a little bit of time here in the beginning, but one of the goals of this year's training, many of you have been through our training before, some of you it's the first time, but when we talked last year about what do we want to focus on this year, and for many of our clients that we have coming back to year after year, we really want to focus on building muscle memory. And what does that mean? It means, responding to fires is not what you do every day. And taking care of patients and doing surgery, that's what you do every day. That's your core competency. And so since responding to fires is not what you do every day, we want to work on building some of those kind of critical skills so that anybody, whoever the first person is to discover a fire, knows what those immediate first actions are. And it could be different in different scenarios, different areas, whether if you're in an operating room or in a PACU setting or somewhere else. And we want to check our Joint Commission and regulatory boxes for doing our annual fire safety. But for me, at the end of the day, I want people to feel empowered that they know what to do if an emergency happens right in front of you. Because if you don't, that's where anxiety and fear and then chaos ensues when there's this feeling of like this anxiety. I don't know what to do. There's an emergency. This is not what I'm used to doing every day. I'm outside of my comfort zone. And any fire emergency is going to put you out of your comfort zone, but if you're empowered and have some of those tools and skills that you've practiced repetitively, that'll help control that chaos. So we start out with our general basic fire procedure review, and everybody knows the word or the acronym RACE, and that's what we use to remember what the fire procedure is. And anybody can remember or memorize these 4 words: rescue or remove, activate the alarm, contain and confine smoke by closing doors, and E for evacuate. Or if you've been in healthcare for a long time, you may have been trained a long time ago that E stands for extinguish. But we like to think of it as evacuate as directed by who was in charge. But how does this acronym, how do these 4 words guide us in our immediate actions? And that's where we have to take the acronym and we have to apply it to a scenario. We have to apply it to a location. And those actions, those immediate actions, might be different depending on the scenario. And that's where we have to use our thinking brain and go through and practice. And what we want to not have to do is have to do too much critical thinking in that emergency, in that time of emergency. What we want is to have that muscle memory. We want things to be rote. We want things to be immediate. I know exactly what to do, what my critical actions are. So that's what we're going to focus on as we go through. Around 3 different general scenarios. Fire in the OR, on a piece of equipment, on something that's filling the operating room or procedure room with smoke. Something that would make it untenable to stay in that environment, vis-a-vis force and evacuation out of the room. A fire on or in the patient during surgery. Those typically do not end up or result in evacuation, but result in significant injury to the patient. So we have to know how to put those fires out. Or a fire somewhere else, an open bay PACU space or same-day surgery or other area. So around these 3 different scenarios, we'll start this time as we usually start with fire on or in the patient. But we're going to go backwards this year. So we're going to start with fire in the operating room, and we're going to talk about evacuation. And we're going to talk about the roles in that evacuation, because this is the thing that you probably don't do that often or ever. Maybe you're involved in practicing a mock evacuation once a year or once every couple of years. And this is where we want to get some more muscle memory built around this. So if we have a fire on a piece of equipment or something in the operating room that is forcing us to make a decision to evacuate the OR, we still got to follow that RACE acronym, that RACE procedure. And the R in RACE tells us to rescue, remove anyone in danger. Well, right now, the room is filling with smoke, and so RACE would tell us, let's pack up the patient and our team and let's move out of here and go somewhere else. But that becomes a challenge when we're in the middle of a procedure and we have our patient open in a sterile field in the operating room. it's not that easy just to pick up and move and roll somewhere else. That results in very significant risk to the patient. And so we have to weigh those risks very carefully. And in the meantime, we have to think, is there anything we can do to possibly prevent having to evacuate and or give us more time to be able to evacuate safely? And this is where circulators come into play. This is why in your operating room you have very specialized set of fire extinguishers that won't disrupt the environment, but are good for use on energized electrical equipment. And so we say maybe, because if we can react to that fire quick enough, if the circulators can get to that fire extinguisher quick enough and can stop that fire from developing or getting worse, we might be able to prevent the evacuation, or we might be able to buy us time so we're not emergently evacuating at a critical moment during our surgical procedure. We have to activate the fire alarm. Any fire, no matter how big or how small it is or was. Yes, even if you have a small fire and you put it out, you still have to activate the building-wide fire alarm. Really important distinction, because a lot of people think, well, if I'm activating the fire alarm, shouldn't I be evacuating people somewhere? Not necessarily. Activating the fire alarm doesn't automatically mean evacuating the room. They're two very separate and different things. All right, and so we'll talk about whose responsibility that is. So if I'm the circulator, and I thought I changed that picture out, I haven't ended up back in here. That's a carbon dioxide extinguisher. Don't pay attention to that one. So what you have are these water mist fire extinguishers. I don't know if the folks in the back can see this. I'll hold it up. It's pretty heavy. I'm not going to hold it up for too long. So big, white with baby blue colors around it. This is a water mist fire extinguisher. Now, you might say, well, water? He's telling me I can use a water fire extinguisher on an electrical fire? Is this guy crazy? Nope. It's deionized water, and the end of this nozzle, when you spray this, it comes out as a mist. It's a powerful mist. It's pressurized, but it is a mist, and it's deionized, so it does not conduct electricity. So yes, this is safe to use on an energized electrical equipment fire. And you have these in your ORs. And that's why we have these there, and they won't disrupt the environment. Many of you probably have a dry powder chemical ABC fire extinguisher at home, or you've seen one. They're around the hospital in common areas, actually one in the cabinet right on the wall right there. If you've ever seen those go off, they have a cloud of powder that comes out of them. And it's an ammonium phosphate-based powder that is a significant irritant to the eyes, nose, throat, lungs, and you would not want to use that in your operating room. It's good for use on energized electrical equipment as well, and other types of fires, but it disrupts the environment and it has a toxic byproduct. And so if you use that one in your OR, that one will force you to evacuate faster than the actual smoke condition from whatever's on fire. So that's why we don't want those brought in. And that's why we don't want, we even have them anywhere near your ORs. And and the National Fire Protection Association, NFPA, encourages you to have the correct fire extinguisher actually mounted inside your OR. So it's right there. You don't have to waste the time to go down the hall to find the fire extinguisher. It's immediately accessible, so you can knock that fire down on that piece of equipment. And then if we are going to evacuate, so let's say we knock the fire down, we can unplug the piece of equipment, we use the fire extinguisher, but let's say there's still some smoke in the room and the team decides we'd be better off getting out of this OR and going somewhere else. Or if we're not able to knock that fire down quick enough and the room is filling with smoke, maybe we have to emergently evacuate. Everyone in the operating room has a role in that evacuation, and it's important we all understand our role. We work together as a team. We practice as a team. So when if we ever have to do a real evacuation, we're not winging it at the time of an emergency. Winging it is not a good plan. You've got fire procedures that dictate or indicate the roles for each person in that operating room, and you should practice these at least once a year so that everyone has some muscle memory of, yeah, I remember when we did this before, and I know what kinds of things can go wrong because I experienced it, and it'll make your evacuations go smoother. Saying, well, I hope everything goes well. Hope is a good thing to have as well, but we don't write that into your emergency plan either. We actually have a plan for this. So our anesthesia providers, they're responsible for everything that's connected to the patient. We have to disconnect all that physiological monitoring equipment. We have to get a bag valve mask and ventilate the patient if the patient's under general anesthesia. We have IVs on poles that need to come down. We have to make sure we take meds out of our med select, our Pyxis, so we can keep the patient sedated, anesthetized during our trip to our evacuation location. Our circulators have 3 important jobs. One is communication. So as that fire emergency starts, if it's on that piece of equipment, your first job is grab that fire extinguisher and attempt fire suppression if it's an option. If it's something coming out of the ceiling or a ventilation duct, it might not even be an option for you. But if it's that piece of equipment, this is first and foremost. Try to stop or put that fire out, prevent or slow down that evacuation if possible. But you're going to need to get that communication step started. And that starts with getting some communication outside of your OR to your control desk. It could be simply opening the door to the hallway and yelling out fire and which OR you're in, or picking up the phone and calling your control desk and letting somebody at the control desk know. Anybody at the control desk that takes that call, or anybody that hears that yell for help, that person circulator yelling fire or calling and saying I have a fire, we need to get the fire alarm pulled for the building, and we need to get the emergency number called. Now it's really important, any circulators in the room, to understand that that responsibility vests with you. So just if you call the desk and you're delegating that to whoever answers that phone, and that's okay, but if you don't hear that alarm sounding in 15 to 30 seconds, understand that the responsibility to get that done is still yours. You may have to actually leave your OR and run and pull the nearest pull station if it's not getting done, or call them back. You also need to make communication connection with your charge nurse, because they're the ones that are going to help coordinate the exact evacuation location for you. Because they're the ones that are going to be calling to other departments and other areas. And we'll talk about evacuation locations a little in a minute. Scrub and surgeon, you're the folks that are at the table with the patient, and you have to determine and figure out, how do we make it safe to move this patient through the hallway to our evacuation location? What do we need to bring with us? Are we going to another OR? Are we going to PACU? Do we need to continue surgery somewhere else? Bring our instrument tray with us. How are we packing the wound? What are we covering the patient with to keep them safe and keep them sterile, keep them in a clean state there? And any support staff that may be around. Clearing the hallway so we have a clear pathway to get from point A to point B. So everybody has a role, and it's not until you actually practice that you'll see what are the challenges that we might face when doing this. One challenge that you might have, depending on how your OR tables are situated in your ORs and the cords that that plug into them to plug into the wall. Are the cords actually physically screwed and connected to the OR table, or can I unplug that cord completely so my OR table is free? Because I want to wheel that patient out of the OR on the table, because that'll save time in an emergency. You won't discover that until you actually practice and try it. So those are the things that we do in our hands-on training. As we're going out the door, the last person out the door, typically the circulator, should be holding the door open for the team to get out of the OR, make sure that the door closes. And this is where I tell the team, take a pause. We're not stopping for minutes in the hallway, but a pause. A 15-second pause once we're out of the OR allows the circulator to make sure the door gets shut, and allows the circulator to now get back in front of the OR table, because our circulator is our snowplow. They're the ones that are going to be clearing things, people, or whatever's in the hall out of the way so we can get to our evacuation location. Doors that you usually go through. You hit a plate on the wall, or you have a proximity thing that you wave your hand in front of so the door's open. A lot of times during fire alarm activation, those devices are not going to work. We don't want doors just opening and closing regularly when there's a fire alarm is sounding, because if there's a smoke condition, the whole purpose of those doors is to prevent the spread of that smoke condition. So it's really important you have that circulator leading the table, because you're going to have to physically open doors and hold the door open for the team to get through. Anytime you go through a set of doors, take a 5-second pause, allow your circulator to get back in front so they're not running to try to get back around to the front of the table as we go. It's important we have that person out front to be doing that lead and opening doors and getting things out of the way. As we come out of the operating room, anesthesia needs to verbalize, typically to the charge nurse or somebody that's going to be staying behind in the area, that it is now safe to shut down the medical gas valves to the operating room. They're not going to be the ones sticking their hand in the wall and pulling those valves. They are hands-on with the patient. They're going to the evacuation location with the team and the patient. But no one is going to be pulling those valves until they hear from anesthesia. That is a clinical responsibility. The engineering and the fire department, they're not just going to go start pulling valves to a room until they hear that it's safe to do it, meaning that there's nothing left, no people left in the room on any life-sustaining med gases. So our C step in RACE, and this is people that are in the area, making sure that as many doors are closed as possible. That prevents the spread of smoke. And no new cases should begin, and that's really important. And this is kind of a large or high job for the charge nurse to do or delegate to somebody at the desk, is you need to communicate to every OR and find out where are they at in their case and when do they anticipate being done, or if they've just moved the patient in and they haven't started yet, to make sure that they don't start that case. They can prep, they can drape, they can start their timeout, they can do everything they want, but don't make that first incision. Don't start that actual case until you get the all clear to begin. I've heard cases where patients have been brought in and they've been getting ready and the fire alarm sounds and they waited, and then turns out there was a real fire emergency and they came in and they say, we need to evacuate you right now. And if they had actually made that incision and opened the patient, that evacuation would have taken minutes longer, which they didn't have, and they would have been stuck in that OR. But you can defend in place in your ORs behind those closed doors for a period of time, and you'll be safe. But if you haven't started yet, wait for the all clear. And it's important also that all the cases that are going on are informed that when the fire alarm is sounding, that if you finish your case, don't just automatically start beginning to move your patient to PACU. Wait till the all clear, because we don't want patient movement through the hallways if there's a fire emergency, especially if that emergency is occurring or going on in your area. Or what if the fire emergency is actually in the PACU area and you didn't actually hear the location? You finish your case, you start moving your patient to PACU, and lo and behold, there's nobody here because they fully evacuated PACU. Maybe that's where the fire was. So you want to stay put until you get that all clear and instructions of what to do next. The evacuation of remaining rooms in the remaining operating room. So if we've evacuated the operating room where the fire occurred, do we automatically evacuate all the other ORs in the suite? Well, that's going to be a charge nurse decision working with the response team, internal response team, engineering and security, and the local fire department when they get here. And together, they're going to work through an evacuation algorithm where they're going to talk about what's the status of the fire in the room where it started. Is it out or is it still going? If it's out, there's no reason to move anybody else. Let everybody else stay in their other ORs, keep the doors closed, defend in place. But if it's an active fire, if it's getting worse, then we're going to start considering moving and evacuating other ORs, especially ORs that are very close or proximal to the OR where the fire originated from. And they'll be working, that's where the charge nurse will be communicating directly with those teams to say, kind of hurry up, we need to start moving you out of this OR because you're right next to or across the hall from the OR where the fire was, and we want to get you out of this area for this proximity. We're only going to move people if the hallway is clear of smoke. If there's a smoke condition in the hallway, if the rescue and evacuation of that OR where the fire resulted in a heavy smoke condition getting into the hallway, we are not going to move patients through a smoke-filled hallway. It's not safe to do it. They're safer staying in their rooms. So that's kind of our evacuation decision. The floor plan, this is one of many of your floors here at the hospital, but what I want to just kind of call out on here so you recognize, and these are part of the fire procedures, are these lines, these red lines and blue lines on here. And those red lines and blue lines represent what we call smoke barrier walls and fire barrier walls. So what is a smoke barrier or fire barrier wall anyway? Well, it's a wall like any other wall, except it extends above the drop ceiling tiles all the way up in through the ceiling space, the mechanical space above the ceiling tiles, and it goes all the way up to the floor or the roof deck if it's the top floor above. And anything in the ceiling space that goes through that wall, because the ceiling space is where you have your mechanical stuff, your wires, your pipes, your ventilation ducts. If any of that stuff goes through any of those walls, it's sealed and caulked with fireproofing material. So if smoke gets into the ceiling, it can't spread and get across that wall. So by having every floor of the hospital has these various walls that are constructed this way, and they're inspected every year to make sure that they haven't, nobody's drilled a hole through a wall and put another pipe or another wire through there and not, protected it with that fireproofing material. But that effectively divides your floor into these different zones or compartments. In the fire code, we call them smoke compartments. And that is one of the fire protection features of the building that allows us to stay inside the building rather than just evacuate everybody to the parking lot, like we did when we were kids in school and the fire alarm went off. Everybody just went outside. Can't do that in a hospital. We have to make it safe for us to stay inside because of the nature of the business and our patients and the acuity of our patients. Some of them can't walk. Some of them are under anesthesia or sedation. And so it's just impractical, unsafe, and impossible to fully evacuate out quickly to the parking lot. So we make it safe to stay inside the building. And this is one of the features that we use when we're designing fire procedures. When we say, hey, what's a good evacuation location for the main ORs? I want to meet 3 criteria when I'm designing those fire procedures. I want to make sure I'm taking you someplace that's on the same floor, because I don't want you to have to take your patient up or down the staircase. Can't use the elevator in a fire emergency, so it's got to be on the same floor, horizontal. I want to get you beyond a fire smoke barrier wall, so to another smoke compartment. And I want to get you to a place that has some kind of clinical capability so you can continue to care for your patient. I don't want to take you out of an OR and send you to a conference room. That would not be a good setup. So if I'm going to take you out of one clinical space, I want to get you to another clinical space that has monitoring equipment, that has oxygen, and has things like that, has people maybe in that area that know how to use that equipment and can continue to help you care and monitor your patients. So with that in mind, we look at some of the predetermined evacuation locations in your fire procedures. If I'm coming out of a main OR, if the fire's in one of the ORs, your evacuation location is going to be going to the PACU. And that's because all your ORs are here in this compartment, and your PACU is over here. And the other thing is, what I like to do when I'm designing fire procedures, if I can have it be a place that you're used to going to every day in your day-to-day operations, because in an emergency, people are going to do, and what they're comfortable doing, and what they're comfortable doing is what's part of their daily culture. So your daily culture is you finish an OR case, you take patient to PACU. So having that be your evacuation location, that it feels natural and normal to you. But there might be some cases or some circumstances where you don't go to PACU. Maybe you have to go to a different alternate location in a different compartment. And those are the nuances and things that happen during an emergency. We design the plan, we write the plan, we train to the plan. Does everything follow the plan perfectly every time there's an emergency? Of course not. We have to improvise, adapt, overcome on the fly. One-day surgery could go to either the E1 surgical or ICU. PACU could go back towards the main ORs, or as an option could go towards E1 surgical ICU. Our endoscopy area could go to our med-surg unit, and then our labor and delivery C-section OR could go towards endoscopy. Again, following those same kind of general principles of lateral horizontal evacuation, same floor, different smoke compartment, some clinical capability in that evacuation location. Because you'll see none of these areas that we have as designated as an evacuation location is like an office suite or a conference room or the cafeteria. That might work for a non-clinical area to go to a non-clinical area, but our clinical spaces, we want to take you to a clinical space. Why is it important with these walls? How important are these walls that they be inspected and caulked, and do they really work? And by making sure that those walls are caulked and inspected and there's no penetrations that are unprotected through those smoke and fire barriers, you can see here in this kind of pictogram here, and it's animated, that a pencil-sized hole through a wall, that's the size of your pinky, a fire generating a smoke condition on one side can equalize a room on the opposite side of the same size through that tiny hole in 3 minutes and 40 seconds. That is not a lot of time, and that is why it's important that those walls be inspected and that we make sure that everything is what we call buttoned up in those ceiling spaces. And here's some examples. The pictures are a little dark, but you can kind of see them. On the left, here you can see some conduit and electrical wires and whatnot going through a wall here, and there's this red caulking material. It's all packed in and around there. So that is a protected penetration there. Smoke is not going to get through that wall. The one on the right here, you can see this one has not been packed, and here you have a pipe going through a wall, and there's a big hole there through the wall. And so smoke could easily migrate through there if there was a fire or smoke condition and get to the other side of that wall. So what's the difference in the pictures there is protected versus unprotected, and it relates to my fire procedures because you want to know when you're looking at that floor plan, and you want to know when we designed your fire procedures, if we're telling you to go to a certain evacuation location and it's in a different smoke compartment, you want to know that you're going to be safe there. And you want to know that you're going to be safe from the smoke condition. Now, a lot of times people will say, yeah, but what about the fire? When people die or get hurt in a fire, what do most people get hurt from? The smoke condition, the smoke inhalation. That's what you hear on the news all the time, right? There was a fire last night on Main Street, and 2-alarm fire, and X amount of people went to the hospital with smoke inhalation. People die in fires from breathing the smoke more often than not being burned by the fire. And so when we have to evacuate a location, we're really looking to get away from that smoke condition. The fire will get knocked down where it starts. Your building is sprinkler protected. Even in this room I'm standing in right now, we're all in this room right now, there's little white caps above our heads if you look above the ceiling there. And the little round white caps, those are your sprinkler heads, and you have them throughout the hospital. They're activated by heat, not by smoke, and if you get a hot enough fire, and it doesn't have to be that hot, about 150 degrees, will trigger that sprinkler head to open up, and you get 20 to 30 gallons of water per minute coming out of that sprinkler head, and it keeps coming and coming and coming. And it'll knock that fire down where it starts. But what it can't control is the smoke spread, and that's why we have that compartmentalization in the building. The doors across the hallway, well, how important are those? Do they really work? I know there's doors that are labeled barrier doors, fire doors. I know they close when the alarm goes off, but how effective are they really protecting us? So if I go to the other side of those doors and I'm in a different compartment, are the doors really going to help protect me? And the answer is yes. And the doors also have to be inspected annually, and there's a 13-point checklist that engineering has to use to check off those doors, make sure that they're working properly. This is a set of real doors in a hospital. There was a fire that happened on the other side of those doors. There was a piece of durable medical equipment in the hallway. It was plugged in, shorted out, caught on fire. Significant fire damage, smoke damage. It actually tripped the sprinkler head in the ceiling on the other side there, so a lot of water damage too. But it's hard to see that you can't see any of the evidence of that from this side. Those doors stayed closed the entire time during the fire. There were actually some patients in some of these rooms here that defended in place in those rooms the entire fire. And not one person was hurt, not one person suffered any smoke inhalation in this fire. That's the other side of the doors. And those pictures were taken one right after the other. It's not like a before the fire, after the fire. It's just different sides of the door. So picture speaks 1,000 words. They actually work. That's why they close automatically when the fire alarm goes off. All right, those are the doors that are part of that barrier wall system. So let's talk about if we have a fire in a PACU or open space. How does that change our response? Well, it changes our response because we can't really defend in place because we no longer have individual rooms with doors to the hall. Now we have one big giant room with curtains between each bay. What kind of protection does a curtain provide you or your patients from smoke condition? None. None whatsoever. So we have to treat it as one giant room. And at your busiest time of the day, how many patients could you have in PACU? How big is your PACU? Anybody? Chad, throw a number out. 18. And could it be full with 18 patients? Yeah? And when you have 18 patients in there, how many staff are in there taking care of 18 patients? Probably about 9. Right? It's typically about half. And so can we evacuate all 18 patients simultaneously? The short answer is no. So we have to know who goes first, who goes second. How do we muster more help to be able to fully evacuate? If I have a significant fire in PACU, every single person in there has to go. We're not making an evacuation decision of should we stay or should we go. It's automatic. We're going. We have no way to defend in place in that space. So that application of race changes in there. Rescue, remove becomes evacuate everybody out very quickly. But don't forget or skip to activate the alarm. Close remaining doors. There aren't that many doors. They're all curtains. Don't bother closing the curtains. You're wasting your time. Just move the patients out of there. If we have an equipment fire, something like that in that space, here we have our ABC fire extinguisher. So if it's something you feel that you can knock down, and you can use that fire extinguisher. But remember, that's the powder one. That one is an irritant to people's eyes, nose, throat. So if you're going to use this, make sure we've rescued or removed people out of the space first. The rescue remove comes first. Extinguishing is last. Once we've gotten people out of the space, the fire is too big, you're not comfortable, don't keep yourself in harm's way. Just get out, let the sprinkler activate, knock the fire down. It's more about life safety preservation rather than putting the fire out. The building is not going to burn down around us. You have that sprinkler system in place. So there's an example of an open bay kind of PACU space. And this is what, let's see if oops, my video's not playing here. It just basically shows you what the dry powder chemical fire extinguisher, how big of a cloud. Anybody seen one of those go off before? I see a couple of people shaking their head. If you use it in training or actually use one in real life, it makes a big cloud, a big powder cloud. It's quite a mess. Our order of evacuation. A lot of folks would think, well, what we can just take, what do we get all the ambulatory people first? We can, there's some people that are kind of really woken up by that point in time and they can self-evacuate and we can get half those patients out of there on their own. Or maybe we should, the staff should focus on the highest acuity patient first. It's not about acuity, it's about proximity to the risk or to the threat, all right? Because if I have a fire, let's say you have 18 bays, if I have a fire in bay 10, if there's a patient in that bay, then they're at the greatest risk. So we're gonna move that patient first, irregardless of what their acuity is. Low acuity, high acuity, it doesn't matter. It's all hands on deck, move that patient, and then once that patient starts moving, then we're gonna move the patient in bay 9, bay 11, bay 8, bay 12, and so on and so forth, moving farther away from that threat, from the risk. So it's the proximity to the fire. Again, fire alarm's activated, going off throughout the hospital. Can we defend in place? Nope, not in PACU, not if the fire's in PACU. Again, ORs, you hear that? No new cases begin. And don't just kind of start thinking you can just move your patients to PACU. You really kind of listen and see if you can hear from where that alarm's coming from. But if you hear fire alarm going off, think like, wait a minute, if we're just finishing up our case, we better double check, make sure that PACU is not affected because we might have to stay put in our OR and begin recovering the patient here in the meantime until we get that all clear. Making sure all other doors in the area are closed. And really, it's waiting for instructions from the leadership team, from the charge nurse. So last scenario here we're going to talk about is fire on or in the patient. And this is where things get a little exciting. We talk about, using some fire suppression and practicing and demonstration. And when we go in our small group session throughout the day, as many people as we can, we'll give you the opportunity to practice the fire suppression as well. And that's a good kind of tactile skill to have in your toolbox, to know you've done it before, you know how to manipulate that surgical towel properly to be able to knock the fire down. But any fire that happens on or in the patient, in the operating room, or any fire in the operating room or procedure room, we initiate the response the same way. And it doesn't matter who sees it first. It could be anesthesia, it could be the surgeon, it could be the circulator, scrub tech. It doesn't matter. Whoever sees it first, we start out by yelling, fire, shut off the gases. Fire, shut off the gases. And I want to make sure everyone gets that down so we understand. And by doing that, we're going to have everybody yell, fire, shut off the gases on the count of 3. Ready? 1, 2, 3. Fire, shut off the gases. Very good. It was more like a mantra, but I'll go with it. It wasn't really a yelling, but it's good. Gets you out of your comfort zone a little bit. It's like, oh, we're yelling in a hospital. This is weird. But being in that fire emergency is going to be uncomfortable. You're not going to be in your comfort zone. It's going to be very uncomfortable. And we need to get the team kind of out of their zone of what they're doing and know that we're now in fire response mode. And we might not be here for very long, or we might be resulting in an evacuation. But in this particular scenario, it's fire on or in the patient. So what does fire shut off the gases mean? The shut off the gases is the instruction to anesthesia to just stop the flow of med gases to the patient from the anesthesia machine. They may be contributing to an oxygen-rich atmosphere. And so, and they may not be, and we can assess that. We might be able to turn the gases back on in a short period of time, but in the initial response, it's fire, shut off the gases. Because as long as I'm delivering med gases to the patient and I have a fire somewhere on or in my patient, fire will have a tendency to burn towards an oxygen-rich atmosphere if we happen to have one there. So that's what we're yelling out. Our actions that we're performing, think race, R, rescue, remove. What does that mean now? I'm applying race differently. Now my threat is actually on the patient. So if the immediate action is, got to put that fire out. You have to suppress the fire. The other thing, as I mentioned earlier, fire on or in the patient rarely results in evacuation of the OR. Fire on or in the patient rarely results in evacuation of the OR. Fire on a piece of equipment, spilling the room with smoke, that's when you're going to be forced to evacuate an OR. All right? We have to activate the fire alarm. So this is the circulator's job. Make your notifications, yell out to the desk, call to the desk. We have a fire, an OR, whatever OR we're in. Pull the alarm, call the emergency number 77, brief the charge nurse. If you're at the front desk, You help make those notifications, make sure the charge nurse is aware of the situation and responding to the OR. And I say that because a lot of drills that we do across the country, every week, we do these evacuation drills, and you'd be surprised. I get it. It's busy. We're busy. We have a lot of patients. We're moving and trying to do a lot of things. And then a lot of times when we're doing one of these drills, we know it's a drill, and it's like, oh, I don't have time for this. But we see a lot of times the charge nurse doesn't immediately respond to the OR where the fire is. And if we're not practicing it that way in our drills, then we're not going to respond that way in the real emergency. We got to practice like it's game day. Tell my kids that when they're participating in sports, and you go to the practice on Saturday, and it's like, oh, and they're kind of half running around the field. I'm like, come on, let's go. Practice like it's game day. Because if you practice half speed, then you're going to respond half speed when it's a real emergency. All right, so put 100% into it when you're doing these drills, and then your response will be what it needs to be. Fire suppression. How do we handle these different fires? Airway fires. So for my anesthesia provider friends, how are we going to you'll be the first one probably to know the airway fire because you'll see smoke coming out of the circuit. We got to immediately disconnect the circuit, stop the flow of medical gases. If the patient's intubated, got to extubate that patient as quick as possible, irrigate the throat, cool the tissue down if it's burned, and reestablish that airway as quick as possible. And that's going to be a challenge. You might be able to reintubate the patient if you can do it quickly. You might have to do a surgical airway to open it up and get it established. As you can imagine, these are the fires that result in the highest morbidity, highest mortality of surgical fire cases. That's what a burning endotracheal tube looks like. They can happen very quickly when the endotracheal tube gets transected, typically by the laser in a throat surgery or upper chest area type of surgery. And that's why now we're doing those types of surgeries. There's special wraps or special endotracheal tubes that have like a metal wrapping that protects the tube so if the laser hits it, it doesn't go through it. But they can happen very quickly. You got to remember to have a fire, you need 3 ingredients. You need fuel, the thing that's burning, you need heat source, and you need oxygen. Now the fuels, and I'm going to go in a little more detail in a little bit, but the fuels, in this case, is the endotracheal tube is the fuel, the plastic of the endotracheal tube. The oxygen is coming through the tube. And in this case, you're probably having a higher concentration than room air, which is 21%. You're probably having a much higher concentration of oxygen coming through there. So you have an oxygen-enriched atmosphere passing through our fuel. And then the heat source is the laser that comes through there. And that's what starts the fire. And then you end up with this jet coming out the side and the end of the endotracheal tube here. And so the way we stop that is disconnecting that circuit. It stops the flow of oxygen or med gas through there. And there's no more air or oxygen feeding that fire, and so it'll go out, and then we extubate. What do we have? A fire in a surgical site: skin, hair, sponge, gauze, in an oral cavity, in a body cavity. These, for my scrub techs out there, when you're setting up your cases, do you have a bowl of saline on your back table 100% of the time? And it's got the water, it's got the saline, it's poured into there, and it's sitting there. This is like having your fire extinguisher always ready to go. Yeah, we use it for irrigation too, but it's always sitting there on your back table. So this is what you're going to reach for 100% of the time. Number one thing is your saline. You have a fire that's in one of these spaces, you grab the bowl, saturate the field if you have to. If you're in a body cavity or if you're in the oral cavity and it's a small gauze or a sponge fire, you have a bulb syringe or a smaller syringe, a flush, take that and you can actually get in there and direct that stream of saline. And you'll be able to put that fire out very quickly. As quick as it starts, fire shut off the gases, grab our saline and we put it out. Get the burnt material out of the patient. And then a lot of times the circulator's sitting there going, do I need to activate the fire alarm now? It was a fire, but they put it out so quick. Yes. The answer is yes. Out of the 50 states, there are 28 states that are mandated to report any fire that happens in a hospital, especially a surgical fire, to the state fire marshal's office and the state health department. And yes, Connecticut is one of them. All of the Northeast, I should say. I was going to say New England, but all of Northeast are included in that list of 28. So yes, and If we have that fire, if it's anywhere near a drape, we want to remove the drapes off the patient to the floor and just check for any extension, see if there's any fire around the patient on the sheet that's underneath them, or if we have chucks underneath them. Make sure nothing else is on fire. What if we have a drape fire? If the actual drape itself is on fire, same thing, we're going to start with that saline. Saturate the area, and you'll be able to knock that fire down. Will you put it completely out? Maybe not. The drapes are a little water resistive, and because they are a little water resistive, the water might run off, and the drapes still might be burning. And now your bowl is empty. Maybe you have another bottle somewhere nearby. It's in a cabinet or it's on the back table, but it would still take seconds to crack that open and pour it in or pour it on. So just simply grab a surgical towel. Hold it the wide way, not the long way, and we're just going to simply use this, come down across the patient, create a barrier, smother the fire out with our hand, and then come off of the patient. So what does that look like using some real fire? I'll use a little bit extra here since he's videotaping. All right, so there's our fire. So what are we yelling? Fire, shut off the gases, right? Take our towel, sweep it out, and the fire is out. This is dry. It doesn't have to be wet. If you're wasting your time trying to get this wet because there's no saline in here, you already threw the bowls empty. Unless it's a matter of your regular practice, I've heard some places will say their regular practice is to keep a surgical towel in the bowl, in the saline, so it's always wet all the time. If that's the case, then you can go ahead and grab that. But if it's not your practice, then don't waste time trying to get this wet. Use a dry towel. You can see it work perfectly here. So just to kind of be in the interest of time, we do have some time. I'm going to ask for a volunteer to come up and just demonstrate. I do this all the time, but somebody that has never done this before or only a couple times, come on up and demonstrate how easy it is to do this. And if nobody volunteers, then I will pick one. And I usually pick somebody in the front row. Come on up. I knew you were. I knew you were. All right, so there's your towel. Yep. Ever done this before? Nope. All right, so there's your fire. So this hand right to here, and then the other hand pull it down, and then sweep again, and then pull it back. That wasn't hard, right? Give her a little round of applause. All right, nice job. Thank you. All right, so we have a few minutes left. So I want to go through and then our E and extinguish. We talked about that. I mentioned our fire triangle. This is our kind of pictogram here that kind of represents the fire triangle. And the fire triangle is really those three elements that I talked about of heat, fuel, oxygen. You need all three to make a fire. So if you think of a triangle, it's got three sides. Each side represents one of those three elements. Fire prevention is how do I keep one of those sides away at any given time? And if I can do that, I don't have the fire. It doesn't happen in the first place. And that's really when we think about surgical fires and the different types of fires that we're seeing and still happening across the country. And yes, there are about 3 or 4 surgical fires a week still happening across the country. And again, only 28 out of 50 states mandated to report. So there might be some unreported cases. So it might be 5. That'd be 1 a day, Monday through Friday. So that means by 5 o'clock today, somewhere, some patient has been burned in an operating room. That's not an acceptable number still. So we've got some work to do as a partnership between our firm, hospitals like yourself, to continue to educate and practice and get best practice to prevent these things from happening. And the prevention is, how do I keep one of these things away? I don't want to bring those 3 elements together on the patient, because if I do, I'm going to have a fire. If I do, how do I put the fire out? You pull one of those things away. And on small fires, the easiest element to block off is the oxygen, like you just did with the towel. Sweep it out, you're getting all the oxygen out, and lo and behold, the fire goes out. All right? It doesn't like have magic fire suppression hands or anything like that. It's just a simple technique using a towel. If we're using saline, when we throw saline, what the saline does, or water, is it converts to steam and takes the heat away. So it's just a slightly different technique, but the result is the same. So how do we know the particular cases where there's a high risk for this to happen? Well, we use a fire risk assessment. You do a fire risk assessment in your timeout to see is this a particular case where we're at a high risk for this to happen. And if we are, what can we do about it? What can we do to prevent the fire from happening? That's the whole reason we do the fire risk assessment. Easy to do. We ask a series of different questions. The standard question list is there on the right side of the screen. That's AORNs, right out of their surgical fire safety toolbox from their website. You might ask the same questions. They might be in a slightly different order, and that's okay. But we want to score them, and if we answer 3 or more of those questions yes, then that's considered a high risk to happen for a fire to happen on the case. And so the questions are, is the location of my procedure above the xiphoid? Am I using an open source of oxygen like a cannula or a mask? Am I using a heat source? The most common heat source that starts fires in the OR is what? The bovie, cautery. It's about 70% of surgical fires are initiated by the cautery. There's 2 other heat sources that contribute significant contributors of heat sources. Light cords, about 20% of surgical fires are initiated by a light cord, and laser, 10%. There have been a few anecdotal cases historically started by bone saws, burrs, drills, defibrillators, things like that, but again, very small numbers. Those are the top 3. So am I using any one of those 3? Yes, then you answer yes to that question. Am I using an alcohol-based skin prep? Right, because that's a very flammable fuel on the skin. And then am I using any of those other things? So that's our fire risk assessment. And looking at those 3 different elements, how does oxygen contribute to the fire here? And it's really important to understand a couple things about oxygen. Number 1, it's not flammable. It doesn't blow up. It doesn't catch on fire. That's an urban legend. All right. It's an oxidizer. It supports combustion. In order to have combustion, you need to have oxygen. It's part of the equation. But it is not the thing that is burning. It is not fuel. All right? You need oxygen to have the fire. 21% room air is enough. If you have 30% or more, that's the definition of an oxygen-enriched atmosphere. So if you're at 30% or higher, so you're using a cannula or a mask. The other thing that we need to understand about oxygen is it's heavier than air. It's not lighter than air. So if our patient is laying on our OR table and we're delivering oxygen by a cannula or mask, over time, the oxygen will build up around them. It doesn't dissipate up into the environment. So we will get, over time, this kind of halo of an oxygen-enriched atmosphere around the patient's head. And if we're doing a procedure in that location, and we're using one of those heat sources in that location, now you can see where we're starting to get the danger. We're starting to bring that triangle together, all right? And so we don't want to do that. So how do we prevent doing that? Maybe we use less oxygen. Maybe we spin the oxygen down when we want to use the heat source. Maybe there's certain cases where we just say, you know what, we're going to go to general anesthesia and just intubate the patient. So we don't create the oxygen-enriched atmosphere around them. So there's different options or different mitigation strategies to prevent that from happening. And the thing to ask is 100% of oxygen delivery necessary? Can we maintain saturation safely between 94 and 99% using a lower flow? Maybe there's some procedures we can do on room air or a cannula at 1 liter rather than 4 liters or something like that. So how it contributes, things that burn well in room air will burn vigorously in an oxygen-enriched atmosphere. And so that's why it's important that we avoid buildup of oxygen under our drapes, why we tent our drapes a certain way so things aren't tucked, so that oxygen doesn't get trapped under our drape, why we use certain types of drapes like our incise drapes, the kind that stick, so oxygen doesn't creep under our drape and then end up in our surgical site away from the head and airway. Certain types of equipment that we have, and I mentioned this earlier, laser-safe endotracheal tubes and things like that, that will prevent heat-resistive tubing, prevent transection of the heat source going through them. Alcohol-based prep solution. And we just have a few minutes here, but we'll talk more about this in our small groups. But making sure that we're allowing it to dry. We apply it to hairless skin only. And that's the pain point right there for a lot of organizations still, is if it gets into hair, any hair, and no pun intended, I'm not going to split hair over how much hair is hair. Hair is hair. If it gets wet with alcohol-based prep, it will not dry in the 3 minutes. You're not waiting more than 3 minutes, and then you're going to drape the patient, and it's going to continue to off-gas or evaporate under the drape. Flammable vapors are now trapped under the drape, and it's a continued fire risk. So 3-minute dry time on hairless skin only. The warnings are right on the packaging. Wet hair is flammable. If you get into the hair, the packaging says it may take up to an hour for it to dry. They know that no one's ever going to wait an hour in the operating room for this stuff to dry. That they're just covering themselves from a medical legal liability perspective. We want you to have a safe practice. We want you to make sure that you don't have a fire on the patient. So only apply it to hairless skin. That means you might have to clip more than you used to doing. All right? And it might be, there's going to take some time for patient tolerance for that. But understanding that, hey, we're trying to prevent your hair from catching on fire and burning your skin, I think most patients would agree that it's acceptable. Clip more hair. Don't worry, it grows back, and we don't want it to catch on fire. If there are certain procedures on the head, you might choose to just use something other than an alcohol-based PrEP solution, such as a betadine solution, which is water-soluble for like craniotomies or temple artery biopsies. Those are particularly troubling cases. There have been 2 of those very significant facial fires in the state of Connecticut in the last 3 years because of alcohol-based PrEP used on the hair, on the face, open source of oxygen and cautery. And they're afterwards saying, well, how did the patient catch on fire? How did they not catch on fire sooner? That's my question. You put all the ingredients of that fire triangle together right on the patient's face. There's no surprise there how that fire started. So there's our packaging again. Lasers and light cords and our cautery, all the safe practice, use of safe practice, making sure things are in standby mode when they're not being used, making sure that the cautery pencil is holstered or it's in someone's hand when it's not being used, it's never set down on a drape, making sure we're familiar with the foot pedal controls if we're using them, what pedals turn on, what pedals turn off, which one is for cut, which one's for coag. Has anybody ever seen one of those little kind of bullet holes or a burn hole through a drape from a cord, light cord? I see a number of heads kind of shaking yes. And those are kind of, we call it like a near miss. All right, you didn't actually have a big fire, but it was a light cord. It only takes about 4 or 5 seconds. An activated light cord on a drape can burn a hole right through a drape. If there was any oxygen on the other side of that drape or around that drape, you could have a vigorous drape fire once that starts. So those are good opportunities to debrief with the team afterwards and say, hey, anybody who saw that? How did it happen? How do we prevent that from happening again? Making sure when we disconnect that light cord, make sure it's deactivated, it's in standby mode, and it doesn't get set down on a drape, so that doesn't happen. We talked about cautery. There's a lot of research being done on bipolar versus monopolar cautery, but do understand that in certain cases bipolar cautery is safer, but it's the tip still gets hot. And so you still want to make sure it doesn't get set down. A bipolar cautery pencil still can catch a drape on fire if it is set down on the drape. So we still want to make sure these things are holstered. The difference is you don't have the electrical current going through the body to the return electrode. So you have less risk of fire with other types of things, jewelry and things like that heating up and whatnot. The different fuels that we have in our environment here. Sponges, gauzes, we mentioned, drapes, equipment, oxygen masks, sheets, towels, chucks, the alcohol-based PrEP. These are all the different fuels that we have. And the one big thing for our gauzes and sponges is making sure they're slightly moistened with saline so that you don't have a dry sponge or dry gauze come in contact with our cautery, with our heat source. There was actually a fire in a Connecticut hospital recently where it was a tissue buildup on the cautery tip because they hadn't been using either the scratch pad or the moistened gauze or sponge to keep the tip clean, and they had a significant buildup of tissue on the tip of the cautery, and it actually caught on fire. There was an open flame, and they were like, oh my gosh, what do we do? And so there was, afterwards they were like, kind of looking at it and scrutinizing it and saying, how should we have reacted or responded to that? It basically, our message is anytime you have an open, unintentional flame, you should be activating your fire procedure. Do you have to pull the fire alarm for every little tiny thing that happens? I don't want staff to be in the business of trying to triage, do I activate the fire alarm or not? If you have an open, unintentional flame, even if it's short-lived, just pull it down, let the team respond, and let them tell you it's not an emergency. And again, remember, activating the alarm doesn't mean you have to evacuate the OR. One is not the same as the other. They're two different things. So we'll wrap up here. Couple questions. Is it okay to bring an ABC fire extinguisher, that's the powder one, into an active OR and discharge it? What's the answer? False, right? That's why we have the special one, the water mist. When evacuating PACU or pre-op, who's the first to go? Everyone for themselves. No, I'm just not kidding. Everyone for themselves, right? Closest to the fire area, proximity. Where's the OR's primary evacuation site should they need to evacuate due to a fire? PACU, right? I hope I'm on vacation that day. And who can make a determination to evacuate other OR's procedure areas in a fire emergency? So like, who makes that decision to do the whole suite, to evacuate the whole suite? Is it the fire internal response team, the charge nurse, the fire department, or some kind of collaboration? Some kind of collaboration. Any questions that I can answer for you right now? I know we want to get going. You got to get ready for cases to start. I'll be up here for a few minutes. If you have questions you want to come up and ask. Otherwise, I'll see you in our small groups throughout the day.